Hello, I'm Dr. Lee Jongkuk from Apgujeong Oracle Dental Clinic. Welcome to the Clear Aligner Master Course. I'd like to talk about the key considerations depending on different types of tooth movements. You may be familiar with this chart. We've been progressing step by step, from diagnosis and order, to the start phase, which we covered in the previous session. Now, we are moving on to the progress stage, specifically the part of monitoring. You might be wondering about what this refers to. After delivering the aligners, the patient begins their regular follow-up visits. In this session, I'd like to talk about what we need to check during this stage. We'll look at 4 main types of tooth movements. There are, of course, many types of tooth movements, but I believe the most common ones are in and out movements, rotation, intrusion, and molar distalization. We'll go over these 4 types one by one and discuss what we should be monitoring for each movement. Let's start with the in and out movements. Some of you may recall that I briefly mentioned this in the previous session. In and out control tends to yield very predictable results with clear aligner treatment. This type of movement tends to go quite well. But don't assume it will always work out perfectly. There's one important thing to keep in mind. If you push the anterior teeth backward just because in and out movement tends to be predictable, it may lead to a deep bite. This is something you definitely need to check. Now, when you look at each tooth individually, you'll notice that in and out movement not only causes anterior-posterior changes, but also leads to vertical changes. So, if you retract a protruded tooth, it can appear to extrude. Conversely, if you procline a retrocline tooth, it may result in relative intrusion. So, it's important to monitor these effects carefully throughout the treatment process. So, in cases involving in and out movements, the predictability is generally high. These cases tend to respond well to treatment. For example, when the anterior teeth are slightly protruded, but there's no need to distalize the molars, especially in the presence of excess space in the upper arch. You can resolve it through IPR. The front teeth can be retracted effectively in such cases. So when you're retracting the anterior teeth using IPR, you must not proceed without careful consideration. In some cases, this can result in a deep bite. When we retract the anterior teeth using IPR, if we fail to make proper adjustments along the way, or if the patient compliance drops significantly, the teeth may become extruded. That's why it's important to monitor for bite deepening when retracting anterior teeth, especially mid-treatment. So you shouldn't just wait until the end of treatment and then realize, oh, the bite got deeper. Be sure to monitor whether the bite is deepening during the mid-treatment phase. If you notice even slight signs of bite deepening, one of the key advantages of Magic Align is that it allows you to submit additional instructions every 6 steps. We can make adjustments through the treatment by modifying the aligner prescription, such as increasing the amount of intrusion force and slowing down the movement speed. I believe these are the key points. As you can see here, number 12 tooth was lingually displaced, but after 5 months of treatment, it moved outward nicely. The alignment improved significantly. However, when you look at the vertical position, the vertical discrepancy between teeth actually became worse. As treatment progresses, after 3 or 5 months, you may begin to notice areas where the aligners don't fit properly. Now, depending on the system you're using, some aligner systems manufacture the full set of aligners all at once. When vertical discrepancies like this appear over time, reordering a new setup isn't always easy due to cost and other limitations. However, with systems like Magic Align, one advantage is that you can request an updated setup when these issues are detected. And of course, as I'll discuss again later, when vertical discrepancies like this occur, you can also use auxiliaries like buttons and elastics to make timely corrections during treatment. Even if you don't need to completely remake the aligners, these cases still require close monitoring. So when issues arise, don't forget that it's crucial to make timely adjustments or request a revision. That's all for in and out movements. Many of you are already quite familiar with them. Now, let's move on to rotation. There are a few key things we always need to consider when dealing with rotation. Please make sure to remember these 2 key points. First, all clear aligner movements require space. If there's no space, teeth won't move. What does this mean? In bracket-based systems, teeth can be forced to move even without space. But with clear aligners, even small movements like rotation require a very slight amount of interproximal space. This is something that's often overlooked. For example, let's say you're doing clear aligner treatment, but the rotation isn't progressing well. Before blaming the appliance, you need to first check whether there is enough interproximal space. Second, the opposing tooth can sometimes interfere with the movement. Especially when you're trying to move an upper tooth, if the lower opposing tooth is blocking it, no matter how much force the aligner applies, the tooth won't move. It might sound obvious, but these 2 points are extremely important. When you're doing clear aligner treatment, you must keep points 1 and 2 in mind. If you can identify the underlying cause, you'll be able to address problems as they arise. That's why I believe points 1 and 2 are critical. I believe that, in the past, rotation used to be one of the more difficult movements to achieve. Even just 20 years ago, there was a general sense that rotation never really worked well. But these days, with advancements in materials and the development of attachments, I don't think rotation is challenging anymore. Also, with rotation movements, there's a risk of intrusion. The tooth may unexpectedly intrude during treatment. To prevent this, when planning the setup, it's recommended to consider some overcorrection as well. So, in this case, even after 3, 10, and 13 months of treatment, there was little to no tooth movement, despite having enough space. In situations like this, before blaming the aligner, you need to ask why the teeth didn't move. In this case, the opposing teeth were blocking the movement, making it difficult for the planned movement to occur. That's why, whenever movement is insufficient, you must always check whether there is enough interproximal space, and whether the opposing teeth interfere with the movement. In general, most of these cases respond well to treatment. However, in cases where the teeth are very small and don't rotate easily, we often use attachments to help facilitate the rotation. So, I believe rotation is generally a predictable type of tooth movement. However, one important consideration is when attachments are incorrectly placed or planned movements are not achieved. In such cases, when the patient wears the aligner, certain areas may make premature contact. This can lead to unintended intrusion and sudden vertical discrepancies may occur. So, don't just focus on the occlusal view, it's also essential to check for any vertical discrepancies from the front view. Let's take this patient as an example. In this case, one tooth requires an inward force. Another tooth needs rotation correction. After proceeding with the treatment, you can see that alignment has been mostly achieved, but a noticeable vertical discrepancy has been observed. A vertical discrepancy has developed, and you can also see that the aligner doesn't fit properly in this area. Based on my assessment, the anterior teeth likely extruded slightly during retraction, and the rotation wasn't fully achieved, which may have caused slight intrusion. So, in cases involving in and out movements or rotation adjustments, it's important to monitor for vertical discrepancies throughout the treatment. If any are observed, make sure to request a revised prescription in your next setup. By keeping this in mind throughout the treatment, you'll be able to achieve more predictable and stable outcomes. Next, let's talk about intrusion. You may have heard that clear aligners are effective for achieving intrusion. I agree with that to some extent. However, this is true only when certain conditions are met. Without the right conditions, achieving intrusion can be quite difficult. That's a very important point. Successful anterior intrusion requires certain favorable conditions. You need to evaluate whether the alveolar bone condition is suitable for intrusion. In some cases, additional support such as mini screws may be necessary. It's best to include overcorrection in the later stages of the treatment. So what does this mean? You might think that clear aligners are great for fixing deep bites. But if we apply clear aligner treatment to this patient with a deep bite, will it really work just as well? If you take a look at the patient's symphysis and alveolar bone housing, it's very thin. Clearly, this is not a case where intrusion seems feasible. The bone condition itself isn't favorable. That's why favorable conditions are essential. When planning for intrusion, it's important not only to assess the condition of the alveolar bone, but also to carefully consider the direction of the intrusion. In cases like this, if intrusion is attempted in this direction, the root may come into contact with the labial cortical plate. This can lead to complications such as root resorption or other side effects. That's why proper direction and favorable conditions are essential for successful intrusion. If those factors are overlooked and intrusion is prescribed blindly, the treatment may not come to an end. That's why I want to emphasize this point. In some cases, using mini screws or applying bite ramps on the lingual side may be necessary. Finally, when it comes to molar distalization, the most important thing to remember is this: any action will inevitably cause a reaction. So when you move the molars backward, there's a high chance that the anterior teeth may shift forward. This is something you must be cautious about. In such cases, it's essential to prevent the reaction mentioned in the first point. You may also consider using mini screws as a helpful approach. To minimize such reactive forces, elastics are used. Also, molar distalization doesn't happen all at once. Usually, the number 7 tooth move back first, followed by the number 6 tooth. This sequential distalization creates temporary spaces between teeth, such as between first molar and second molar, where food can get trapped during treatment. You must inform the patient in advance that food can easily get stuck between the teeth during treatment. If you explain this beforehand, the patient will understand. But if you wait until after the problem occurs, they will often complain that it was very uncomfortable. So it's important to pay close attention to this. In Class 2 cases, when retracting protruded teeth, planning molar distalization can be a very effective strategy. So the molars are moved back one by one. The second molar first, followed by the first molar, creating space for the canines. Interarch elastics are often used to prevent the proclination of anterior teeth. By placing these elastics, we can ensure that only the molars are distalized while minimizing the proclination of anterior teeth. These interarch elastics are very helpful in minimizing side effects due to the action-reaction phenomenon. You can achieve results like this. On the other hand, if you look at this case, the treatment was designed to distalize the molars in a Class 3 case. However, when the force and reaction effects were not considered, although many screws were used, the anterior teeth ended up significantly proclined compared to the maxillary teeth. As a result, additional screws had to be urgently placed in the treatment to minimize the unwanted reaction. Even when you distalize just one molar, you must always check for the risk of anterior teeth moving forward as a reaction. That's why sequential distalization is standard. When you're moving just one molar distally, such as the second molar followed by the first, this is referred to as a 1-on-6 situation, where a single molar is being moved against the resistance of 6 anterior teeth. In such cases, there is still a risk of proclination of the anterior teeth due to reaction force. So it's essential to control these forces to ensure proper molar distalization. Today, I discussed topics related to monitoring and how they are connected to different types of tooth movement. If you keep in mind the 4 types I mentioned earlier and carefully monitor for any unintended movement in these cases, I believe you'll be able to achieve predictable outcomes. That's all I've prepared for today. I look forward to seeing you again next time with another useful topic. Thank you for watching.